Hi, everyone. My name is Tapan Kadia. I'm currently faculty in the Department of Leukemia at MD Anderson Cancer Center in Houston. As I was reviewing the ASCO abstracts for this year, 2021, I found a few that I thought would be interesting in the subject of leukemia, and I'm going to just briefly tell you about them. So the first is one that looked into CML chronic phase, optimizing the dose of Ponatinib in CML. That was abstract number 7,000. They used 3 dosing regimens where they looked at starting at 45 milligram dose and transitioning to 15 milligrams when the BCR-ABL was less than 1%. The second arm, which at 30 went to 15, and the third arm, which started at 15 altogether. And what they found is, as you would expect, the response rates were the highest with the 45 milligram dose, but dropping to 15 really helped with the safety. So there was an optimal risk benefit when patients were receiving 45 milligrams of Ponatinib, followed by transitioning to a lower dose of 15 milligrams once they had achieved a BCR-ABL level of less than 1%. There was reduced incidence of arterial thrombotic events, which were higher in the PACE study. And certainly the responses were higher than the 30 milligram or 15 milligram dose. Another abstract was in patients with ALL, also looking at Ponatinib. It was a small pilot study of patients receiving Blinatumumab and Ponatinib. As you may remember, there was a recent study in the New England Journal of Medicine that demonstrated significant activity with the combination of Dasatinib and Blinatumumab. In this study from MD Anderson, about 35 patients were treated with Blinatumumab plus Ponatinib. Among frontline patients, or 20 frontline patients, the CR/CRP rate was 100%. But more impressively to me, the rate of complete molecular remission was 85%, suggesting a very deep response in a non-chemotherapy regimen for newly diagnosed B-cell Philadelphia positive acute lymphoblastic leukemia. In the relapsed refractory arm, the CR/CRP rate was 89%, but also a CMR rate of 88%. So also pretty high, and again, very well tolerated. Interestingly, there was a cohort of patients, 5 patients, with CML lymphoid blast phase where the responses were lower and the outcomes long-term were also lower. But I think certainly in frontline, this is a promising study to look at, and we'll wait for more mature data. Staying in the ALL space was the study from the KITE CD19 CAR T cell, the so-called KTE-X19 CAR T cell. And it was a phase 2 study in relapsed refractory patients, which demonstrated a very high response rate, 71% rate of CR/CRI among 55 evaluable patients, with a median overall survival of 18.2 months. Importantly, responses were seen throughout all subgroups, including those patients who had prior Blinatumumab, which was about 45% of the entire patient population. So again, a very well tolerated. CRS was there in about 89% of patients. Neurologic toxicity in about 2/3 of patients, but very well tolerable. Toxicity was mitigated with appropriate measures, but the response rates and the durability were impressive. And we await the final manuscript of this as well. Moving on to CLL, there was a study of Acalabrutinib versus Ibrutinib. So 2 BTK inhibitors in patients with relapse and refractory high-risk CLL. Patients had to have 17p deletion or 11q abnormality. Patients were treated with Acalabrutinib versus Ibrutinib. It was a non-inferiority study, and indeed, as a primary endpoint, Acalabrutinib was non-inferior in terms of progression-free survival compared to Ibrutinib, so that was good and met the primary endpoint. They had very important secondary endpoints, which I think were really the crux of the abstract, which it showed a significantly lower rate of cardiovascular events in patients who received Acalabrutinib compared to Ibrutinib. Specifically, lower AFib and flutter, about 9.4% with Acalabrutinib compared to 16% with Ibrutinib. Hypertension was also lower, 9.4% versus 23%. So clearly better tolerated. So overall, sort of equal efficacy, but better tolerability with Acalabrutinib in the head-to-head trial. And finally, a smaller study, sort of a poster, but also interesting, and the reason I highlighted it because I think it could potentially be in the future practice changing, was a very small pilot study of Enasidenib, which is an IDH2 inhibitor, in patients with high-risk IDH2 Mutated MDS. And so in patients who were untreated, patients were given Enasidenib plus azacitidine. There, the overall response rate was 84%. a second cohort among HMA failure who had received prior HMA and then progressed. The response rate there was 43%. And I think the most impressive in this very small cohort of patients with, again, short follow-up, was that in those patients with post HMA failure, single agent IDH2 inhibitor, which is enasidenib, demonstrated a median overall survival of 21.3 months, which is much better than what we would expect in the range of 3 to 4 months in post HMA failure. So I think those abstracts were interesting, and I hope you get a chance to check them out. And thank you for listening.